Welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. It is my great pleasure and privilege to introduce my partner, Dr. Greg Caldwell, also co-owner of Optometric Education Consultants, who will be doing our talk this evening. Thyroid dysfunction, thyroid eye disease, everything that you need to know and more. Greg is a disease consultant in Pennsylvania, in Duncanstown and Johnstown, PA, Duncansville. And he has been involved in numerous clinical studies. He has lectured throughout the country and across the world. He is really one of our foremost educators that we have out there. And he has worked tirelessly as a supporter and proponent of organized optometry, having been POA president, as well as an AOA trustee for 3 years. I've heard Greg talk about this topic. This clearly is what I refer to as his Sergeant Peppers. This is some of his greatest hits. So with that, give a nice virtual welcome to Dr. Greg Caldwell as we talk about thyroid dysfunction in the eye. Greg, take it away, please.
Thanks, Joe. And thanks everyone again for being here tonight. And this is probably one of my funnest lectures to give, because I'm going to take a bet. Maybe I should have made it a polling question, or maybe I did. Maybe it's number 9, is that you'll probably have someone in your office that has thyroid eye disease and you just didn't realize it. And hopefully after tonight, you'll be able to recognize that person, recognize when those patients come in and be able to help them out. And there is a newer treatment out. You're probably seeing it advertised on TV as much as I am, by Horizon. And I'll explain how that works in the target and how to refer for that treatment. All right. With that being said, the content of this was prepared by me, independently by me, no outside influence. And really these next 2 bullet points, where I lectured from Alcon to HERU, and then the advisory boards from Allergan to Inova. Recently, I've been explaining that I don't really put that up there to kind of as bragging rights. I put that up there as a clinician in Duncansville, Pennsylvania, as Joe mentioned. I live in a town of 4,000, about 100,000 people in the nearby city where I practice, with counting all the little surrounding cities. And that's really just there to show you that if we want to stay ahead of the curve and offer you up-to-date information, it's just a way for me to kind of stay in touch and be able to deliver to you, and then hopefully make everyone improve clinicians. I do sit as the PA medical director for Involved with Managed Medicaid. I'm helping out with a registry. I'm the diabetes and now AMD chairman for advisory. Most importantly, I don't have any direct financial interest in any of the companies or products. I might mention the Maculogic, OCT, OCTA, and the Pharmanex scanner in here. I do have those in my practice. But most importantly, I'll present anything here without commercial bias and not claim any superiority. And Joe already mentioned half owner, and you can see there where we do our live meetings. Now, we always got to do the financial disclosures. How about financial obligations? Here's my wife, my son. Need to update the picture. He's now 19, but we can see here we're big Disney fans. I was just in Florida helping out with one of the local societies. Love that state, love Florida. Flew home today and now doing the webinar. Again, I just want to talk about my practice. I do practice just like everyone else does. Go to work, see patients. I'm doing it 3 days a week now because I'm typically lecturing Thursday or Friday. But we do have our own little building. We have electronic health records. You can see I have an optical. We got lots of fun equipment in the practice though. But I just want everyone to know that I go to work and see patients just like everyone else does. Now, I've been doing some, it's really been rewarding over the last, last year, 18 months, really moving into, if you want to say, integrative, complementary type of medicine. About 4 or 5 years ago, patients were coming in and asking about, hey, what vitamin should I be taking for my thyroid, my macular degeneration? I'm a macular degeneration suspect. And it got really confusing. I said, well, it wasn't confusing at that point. I said, well, I'm connected with all these companies. You saw my list there, and let me start digging into this. And it was like unearthing a tree. So I started taking some functional medicine courses and going to conferences just like we have in optometry. And this was a conference that I recently attended in December. And James Laval was speaking, and this basically a screenshot of his slide. So I want to give a little bit of a shout out to James Laval. And he was talking about, aging and performance and vitality out there. Again, we've grown up in this allopathic model. This is more getting into prevention and root cause. And so oxidative stress is where I've been focusing on in my practice, but hormonal balance and stress and glucose, and then that gut microbiome, the whole microbiome all over. There's a skin, there's an eye, but the gut and how that's kind of now communicating to the brain and immune balance and exposure and burden. So I thought it was really cool about this hormonal balance and stress hormones and glucose. And that's what we talk about today with thyroid. And this is another slide whenever I was there. Philomena, it was an MD, and she thought she was getting into healthcare, she would say, but she was getting into sick care, but wanted to help people. And she came up with this Sade's hormonal symphony, and it's trademarked. So I want to make sure I give her the shout out that she deserves. But she was talking about a case where, someone's thyroid was off. She was just telling a story there. And, she was saying like the allopathic doc was trying to fix the thyroid issue, but really it was a little up chain where the issue was there was insulin resistance, creating a little cortisol issue. And then once that was fixed, they really never had to do anything with the synthroid. So she's basically trying to explain here, this whole synthroid, this adrenal complex with cortisol. And then we're going to really hammer tonight on this one specific area, kind of the allopathic side, or mainly the allopathic side. But at the end, I'll talk a little bit of the functional side. And then the sex hormones that are out there, and then the estrogen metabolism and how that all kind of cycles together. So with that being said, let's just jump in and talk about thyroid disease and thyroid eye disease that's out here. And the first polling question that we'd like to bring up is, and this is we're going to set the tone here. Got a lot of polling questions here at the beginning, and I'm going to watch the chat here. I want to see what happens as we do this. And it looks like Joe's already put the handout in the chat box. What type of disease is thyroid eye disease? Is it a cornea disease? Is it a glaucoma disease? Is it retina? Is it neuro-op? Or is it something else? And if it's something else, I'll keep the chat box open to see if someone wants to type anything in there, and I'll keep an eye on it as the poll rolls in. So again, if you're going to classify thyroid eye disease that we see in the practice, if someone has a retinal detachment, we send them to a retina doc. If someone, has some type of, maybe third or fourth nerve palsy, we might send the person to neuro-op or Joe Salka if you're down in Florida. What type of disease? And I see that someone's put autoimmune. EOMs can be affected. That is correct. And so, John, we're going to end the poll.
All right.
And I'm going to share the results. And, a few people put cornea, one put glaucoma, no one put retina, neuro-op. It does have a neuro-op component at the very end. That's not where I was going for it. The 42% of the majority is other. And I see inflammatory, and then the doc here has got it. This is the word I was looking for. Orbital disease. When it comes to thyroid eye disease, it's an orbital disease, and it's an inflammatory, but not all thyroid has to be inflammatory that we're going to talk about. So it's an orbital disease. That's what I wanted everyone to realize. It affects the fat, it affects the muscles that are within the orbit. So if you're going to look for a specialist, we want to look for an orbital disease specialist when it comes to treating it. The thyroid is an endocrine gland. There's two types of glands. There's endocrine and exocrine. Endocrine just means it's a ductless system. It's using hormones. There we go. We're back to those hormones. And the hormones that are affected in this condition that we're going to be talking about, we're going to be talking about T3, T4, and TSH, and thyroid releasing hormone. The endocrine glands that are out there are the hypothalamus, pituitary gland, and thyroid. And I'm not going to read that list to you because you guys can all read, but the thyroid falls within the endocrine system where it's a ductless system. Exocrine means that there's ducts involved. So there's tubes leading from the gland to the target organ. So digestive enzymes. from the salivary gland, sweat glands that go into the intestinal tract. And then I really like the pancreas because the pancreas is both. And if you think about what happens with the pancreas, we got insulin, and we talked about insulin resistance and the glucagon whenever we were talking about the symphony that I showed earlier. But we also have digestive enzymes that secrete into the small intestine to help out. So the cool thing about the pancreas, it's both endocrine and exocrine. The thyroid is the largest endocrine gland in the body. It's butterfly shaped, 2 lobes just below the skin and muscle fat layer. I think we're all familiar. And the primary focus of the thyroid is to produce T3, T4, and calcitriol. That's the main purpose when the thyroid stimulating comes down from the anterior pituitary, hits those receptors, and it creates T3, T4, and the calcitriol. What we'll talk about at the end here, I threw some integrative or functional, whichever way you want to call it. You'll see that T4 is what's produced 95% of the time, and it needs to be converted to T3 that's out there. Now, normal thyroid function can start here in the hypothalamus. The hypothalamus produces thyroid releasing hormone, which then talks to the anterior pituitary, produce thyroid stimulator. Remember, this is all ductless. That it's done via blood and the lymph system. That's, there's no tubes that connects the hypothalamus down to the anterior pituitary. And then the thyroid stimulating, I'm going to say a few things over and over again tonight to help drill this in. Hits the receptor of the thyroid and produces, as you can see here, T3 and T4. Now, here's what I like to always point out. This guy comes into my office and he tells me, hey, doc, if you tell me I got a thyroid problem, if you send me for one more thyroid problem one more thyroid panel, I'm getting up and walking out. And I was kind of like, hey, John, pleased to meet you. Greg, I'm an eye doc. I'm here to see you today. That was kind of like the opening remarks. But you could tell that he was a little bit frustrated. You can see that he does have some thyroid eye disease, a little bit of redness, a little bit of bulging. And when I chatted with him, I just basically said to him, look, I think you have a thyroid dysfunction, which is affecting your eyes, but it doesn't mean that your chemical messengers have to be out of control. And that's probably why your panels are all coming back normal. He's like, okay, doc, I'm intrigued. I'm not getting up and walking out. Let's talk a little bit, because everyone seems to be tying this in, but maybe you have an answer. So, and then think about the whole, that whole cycle that I started off with. When you have insulin resistance, that's usually where a lot of this stuff starts. If you talk with Filomeno, you have to always make sure the patient isn't insulin resistant, because then it can mess up that cortisol, thyroid, those sex hormones that are out there. So with that being said, Joe, can we do the next polling question?
Yes, we can.
I see maybe some answers that have rolled in that can kind of touch on this, but what is the most common cause of thyroid dysfunction? Cancer, surgically induced, medication, is it pregnancy, or is it autoimmune disease? So which one is it? Medicine, toxicity, surgically induced, cancer, pregnancy, autoimmune. These all cause thyroid disease. Every single one of these can do it. And I saw in the chat box from the earlier questions, I see inflammatory. Lynn put autoimmune. And looks like we got a pretty good response.
Yes, we did. Very fast.
Yeah, good. That's making this interactive. There you guys go. See, we're interactive. We're doing this with the proper regulatory people would be happy. All right. So with that being said, we have the number one cause here. One person put cancer. We have medication, toxicity, pregnancy, and the majority of the colleagues put is autoimmune. And autoimmune is certainly the way we go. In autoimmune disease, the body typically produces what that attacks itself. And we could say antibodies, or we could say immunoglobulins, right? If you want to be really fancy, the body's made these immunoglobulins or these antibodies. And we're really going to focus on that tonight. You're going to be sick and tired of hearing me say receptors and antibodies or immunoglobulins by the time this lecture is done. So let me just kind of show you where thyroid dysfunction can occur. We're talking about the hypothalamus up in the brain. Joe, I mean, I'm sure you probably know, but I don't really know. Is that like the hypothalamus is like the midbrain, or is it above the midbrain, or where is the hypothalamus located?
It's midbrain.
Is it midbrain? So we got the hypothalamus in the midbrain that if someone had some type of trauma, maybe a stroke, closed head trauma, and they didn't produce thyroid releasing, they would then not produce thyroid stimulating, and then it would not produce T3, T4. That person would end up on Synthroid. Let's say you're having a great day as an optometrist, you're doing your confrontation fields, and you pick up on this bitemporal, you run the visual field. If they definitely have a bitemporal hemianopia, you send them for the MRI. They have a small orange size pituitary adenoma. They go up through the nose, do a pituitary ectomy. They take out the tumor. And that patient now has a breakdown between the thyroid releasing, thyroid stimulating. So they're going to end up on Synthroid. Some people have thyroid cancer, and I've heard them been radiated and surgically removed. That person's going to end up on Synthroid. But none of those are really at risk that I just told you about for thyroid eye disease. They're all on Synthroid, but they're really not at risk. So what chemicals, in this polling question, what chemicals cause the thyroid eye disease? Is it the thyroid releasing hormone, thyroid stimulating? Is it the T3, T4? Is it the thyroid stimulating immunoglobulins, blocking antibodies, thyroid peroxidase antibodies? So what chemicals cause the thyroid eye disease? Now, to kind of start tying things together, right? It's an orbital disease. So it's an orbital disease feeding off of what some of the colleagues have put. It's an inflammatory orbital disease. And think about it. When you have chronic inflammation, it's never good. Chronic inflammation in a knee ends up with arthritis, or is arthritis, ends up with advanced arthritis, bone-on-bone knee replacements, hip replacements, chronic disease, heart disease, inflammation ends up with heart attacks and blockages of the coronary arteries. So anything that has chronic disease, chronic inflammation, again, that oxidative stress that we were talking about a little bit earlier, that can cause some issues. So with that being said, we have a nice little mix here of answers. And you can see here that we have about 30% saying the thyroid releasing, thyroid stimulating, and then about 18% saying T3, T4. The majority of the audience here at 53%, if I was phoning, I would definitely take that answer. And it is the immunoglobulins, these antibodies, these autoimmune antibodies that the body produces, right? So going back and tying into it, is it now back to the gut biome? Is the gut leaky and creating inflammation? And then you create these immunoglobulins, which then go and attack. You know, that's kind of a thought that's out there, trying to tie in some of this functional and integrative. You know, is it just that your body is making these, that you're just genetically predisposed to forming these antibodies that are out there? But it are these antibodies in this autoimmune. So remember, orbital disease. It's an orbital disease. Thyroid eye disease is a disease of these antibodies that attack the receptors of the thyroid. But then the issue is, and here's the cat out of the box, is that unfortunately, the orbital tissue has receptors that look very similar. The fat, the muscle have receptors that look like thyroid receptors. So when your body produces these thyroid stimulating, as I'm highlighting here, thyroid stimulating or thyroid blocking or thyroid peroxidase antibodies, And it's a receptor disease. So you remember there's type 1, type 2, type 3, type 4. Type 1 is immediate, type 4 is delayed. Type 2 is when you get a reaction in a hypersensitivity because receptors are being attacked. That's what's happening here. The antibodies are formed for whatever reason, known or unknown reason. They go and attack the thyroid. That's what eventually creates the T3 or T4 burst, the hyper or hypo. But then there's only a finite amount of receptors. Eventually, the receptors get damaged from the attack from the antibodies. And in a sense, they start looking for other tissues. And then unfortunately, again, the eye has these receptors. So what happens in hyperthyroid, you can see here thyroid stimulating in this whole cascade. Remember, thyroid releasing, thyroid stimulating. These thyroid stimulating immunoglobulins or antibodies go and hit the receptor. And since they're stimulating, it creates the burst of the T3 and T4, which then in blood work looks like a decrease in TSH because it's a big negative feedback loop. It all kind of talks to each other in this ductless type of system. And that's what we were taught that looks like hyper. Now, what happens in the autoimmune disease side of this is that if someone comes in and they have thyroid blocking as their autoimmune disease, then it hits the receptor and blocks it, slows down T3, T4. And then what happens is in the negative feedback loop, that's the increase in TSH. It's saying, hey, look, I'm not getting enough T3, T4. Come on, TSH, spit it out, get down here. But it's a disease, it's an autoimmune issue. And that's what hypothyroid looks like. So if you found a pituitary tumor in an eye exam, the patient had successful surgery, pituitary tumor, we talked about it. The patient is now on Synthroid. Is this patient at risk for thyroid eye disease? Yes or no? See, again, we talked about this patient, right? We had this patient that has pituitary tumor. You found it, visual field, MRI. You just took out the part of the system that produces TSH, can't produce T3, T4, so they end up on Synthroid. Is this patient at risk for thyroid eye disease? And we'll just wait for the polling questions to roll in. I don't see any questions in the chat box.
Nothing new in the chat box.
Great. All right, great crowd. Look at the participation rolling in. Guys are making it interactive. Love it. And I'm going to just end the poll. Thanks for launching it, Joe. I'll share the results. And you guys can see here now we've got a little bit of a mix, right? We've got 42% saying yes, and we have 58% saying no. And if I was going to answer this question, I would put the answer as no, for the fact that this is really not an inflammatory type of condition, right? The antibodies that this is not really an antibody disease, right? The patient had cancer, the pituitary tumor, no really autoimmune condition going on. So really no antibodies to go and attack the orbit that's out there. I'm not saying that they couldn't maybe have some T3 or T4 issues. So basically I'll give everyone credit in a sense, and I'll show you in that slide when I get there, where you could have some eye symptoms, but it's not the chronic inflammatory symptoms that I was going for. So there's kind of in thyroid eye disease, kind of the T3, T4 excitable or slowing down findings, and then there's chronic inflammatory findings that are out there. So I'm just going to animate this whole slide just to kind of show you that there's, under the hyper side, there's primary autoimmune Graves' disease, and then there's thyroid, or there's secondary and tertiary, and you can see the list. And over here under hypo, again, you got primary autoimmune, which is Hashimoto's, and you can see the list there. And there's some reasons why you can get some secondary and tertiary between some lithium medication surgically induced. when you look at this whole list, what we're going to talk about and focus on, and now where Tepezza, the what you're seeing advertised on TV, this is where it's focused in this chronic inflammatory autoimmune disease, not really these secondaries to like lithium or excess iodine or cancers that are out there. So all these people that in this list here are going to end up on Synthroid. It's just which ones are at high risk for the thyroid eye disease. It's the autoimmune, because now we got the antibodies involved in those receptors.
Excuse me, Greg.
Yes.
Is what would cause TSH to suddenly kick back in?
What would cause TSH to suddenly kick back in?
Yes, if somebody has been treated with Synthroid and they have low TSH, and TSH starts to come back or is produced, and they end up in a hyperthyroid medically induced. I mean, what would cause that to happen?
Are we talking in an inflammatory or just someone in general that's out there that just they all of a sudden that they are chronic inflammation? Did they all of a sudden they just had a drop in TSH?
Well, this was a patient I had seen who had low TSH, was being treated with Synthroid.
Mm-hmm.
And when I saw her, I mean, she's had some double vision issues, fourth nerve palsy, actually unrelated. But she comes in with that, slightly lid retraction, very chemotic conjunctiva, and I wanted to get some orbital imaging. And I actually talked with her primary care physician. He said her TSH suddenly went up, and now he thinks it's all exogenous medication that is causing her hyperthyroidism. And he said, let's wait on the imaging and stop the medicine and see what happens to her, which I of course agreed with.
Yeah, so it goes back to that kind of one of those opening slides that I was talking about. And this whole cascade, if we look at thyroid disease without bringing in all the other hormones that can affect it, maybe insulin resistance, or could have been some stress in the family, cortisol. So in that whole hormonal cycle, we kind of have to look at it as a holistic approach, looking at thyroid eye disease and keeping those. So that could have been influencing the TSH. But also now the flip side is, the patient might have maybe said, hey, let me see a naturopathic doctor. Let me start taking some nutraceuticals. And one thing I've learned is that, in this oxidative side, and a lot, we're familiar with in optometry in the allopathic thinking, but folding in some complementary or integrative, is that what I've learned is that we're used to oxidative stress as in macular degeneration that's out there, but oxidation and free radicals damage the receptors. And so now if a patient is taking some nutraceuticals and maybe taking care of themselves, eating better, all of a sudden now the TSH is now being able to be produced, the receptors are not oxidized, and the body starts to heal. So that would be a good thought of where that came from.
Yeah, as I said, she was losing weight, wasting, was very jittery, and a very, very chemotic conjunctiva. I knew that she was on Synthroid for thyroid dysfunction. And as I said, I was going to get the orbital imaging, but I spoke with her primary, and he said, no, her TSH just kind of shot through the roof. And the additional Synthroid probably is putting her over the edge. So let's just stop medication and see what happens to her.
Yeah, she might have been healing a little bit on her own. So yeah, that's the issue with these conditions. Whenever they're inflammatory, how, are you chronically inflamed? How many receptors are damaged? Which receptors? It's tough in these first few years because of this chronic. It's like people with arthritis, I have a good day today. I can walk today. Oh, I walked a lot yesterday, inflamed my knee. Now, I went to Disney. Now I walked, 2 parks, and I got to set a park out on the 3rd day because of inflammation. So, lots of moving parts here in this inflammatory cycle. So Graves' disease is a multi-disorder. I think we're used to it, of hearing it, but it's the infiltrative dermatopathy. You get some derm because, again, skin receptors look like thyroid tissue. That's where you get the infiltrative ophthalmopathy. We'll talk about it. And then we have the prevalence with these autoimmune conditions. It's 7 to 1 in the females. But if you go back, if I went a little bit too quick, you could see here that the etiology is this thyroid stimulating immunoglobulin or antibody. When it comes to Hashimoto's, it's the most common form of thyroid dysfunction in the United States. It's the goiter formation. And again, you can see here, it's again an autoimmune tied into these antibodies that we talked about, peroxidase antibody and the thyroid blocking antibody is usually responsible. And again, another autoimmune condition, atrophic thyroiditis, the trophic thyroiditis, similar to Hashimoto's, just no goiter present. Women can develop antibodies during a pregnancy and then inflammation of the thyroid after delivery. Now, I think we're all familiar with the side effects of hyperthyroidism, as Joe was mentioning earlier with his patient. The patient's T3, T4 was very elevated, creating the wasting, the nervousness, the heat tolerance, the sweating, the palpitations, the hypertension, diabetes, and so on and so forth. Again, you can see folding in now more of those hormonal systems, but the thermostat is just turned up, as we were taught. In hypothyroidism, as you can see here, now the thermostat is turned down. You become cold intolerant, weak, reduced energy, that deep voice, the monotone, bradycardia rather than tachycardia. So in all of these conditions of the autoimmune, you could get thyroid eye disease. There's different names that are out there. So I like going over the names just to kind of remind us again what we started off at the beginning of the lecture, right? So Graves' disease should really only be used if the patient was hyper, but it kind of reminds us that it's an orbital disease that's out there. I like thyroid-associated orbitopathy. I like thyroid orbitopathy. This thyroid eye disease I like here. That's why I just call it thyroid, as you guys heard me say it a million times already. Ophthalmic Graves' disease, inflammatory reminds us that it's an inflammatory condition, inflammatory eye disease, or endocrine orbitopathy. So again, lots of these are very good to remind us, you know, where the disease is, what's causing it, and it's these antibodies. Now it becomes confusing because you can see this thyroid eye disease in conjunction with Graves' disease. You can see it with Hashimoto's. You can see it when patients like the guy that I started off with came in and he had no evidence of thyroid dysfunction. You know, most thyroid patients will, however, will not develop thyroid eye disease. That's really the kicker. So even though there's a large amount of patients that have autoimmune disease, they don't always get those antibodies attacking the orbit and then those receptors, or we might just be missing it. And maybe hopefully after tonight's lecture, we'll be able to pick it up. The symptoms usually occur the same time of the thyroid disease. However, they can precede before, right? So they can proceed after, just kind of like this gentleman that I was having in my chair. He's got these bulging eyes. He's really not tired. He's really not, slowed down. He's not really having any of these issues, but yet, he's got these ocular symptoms that are going on that's out there. Anytime someone has a autoimmune condition, beg, plead, grovel with them, try to get them to not smoke anymore. That's just one of the, smoking's bad in general. Put 2,000 or how many toxins there are in a cigarette in someone that's already has a heightened hyper autoimmune condition, immune system that's really, really sensitive already, maybe due to leaky gut and these other causes that are out there. But yet we don't want to be putting in any other toxins that are out there. So while the eye disease might be brought on by thyroid dysfunction, this is now the kicker. Successful treatment of the thyroid gland does not guarantee that eye disease will improve. And that's really what I want to point out here tonight. If we're trying to treat thyroid eye disease and monitor thyroid eye disease by following T3, T4, TSH, we're going to have errors here. And I can't tell you how many times I've had to call up physician assistants, primary care docs, and even endocrinologists, where I've told the patient, hey, look, you have thyroid eye disease. And they say, how can that be? Your T3, your T4, your TSH is perfectly normal, how can you have thyroid eye disease? This is the best your T3, T4, TSH numbers have been in a while. And that's when it's a call to the PA, to the primary care doc, and say, because it has really nothing to do, this chronic inflammatory disease doesn't have anything to do with the T3, T4. It has to do with the antibodies that are out there. So let's say we are a support group, right? We have how many in here tonight? We have 95 people. So let's say we have 100. We have 100 people in this here tonight. Every single person in here is suffering from thyroid eye disease from one form or another. So when you present, what if I would say, how many of you were hyper at the time of diagnosis? How many would raise your hand? Or if you're suffering from thyroid eye disease, how many of you were hypo at the time of diagnosis? Or how many of you were euthyroid? So which would be the majority in attendance? Would it be hypo, euthyroid, or hyperthyroid? Again, which one of these causes? Is it hyper, euthyroid, or is it hypo that creates the majority of the thyroid eye disease? Yeah, the chat box looks pretty good. And nice rolling
We're
in.
cruising along very nicely, Greg. Everything is good here.
Yep, go ahead and we can stop. Oh, we got a few more rolling in. But if you want to end the poll, Joe, that would be great. So we see here that it's a nice mix, right? We have 31% saying hypo, we got 18%, and then we've got 51% saying hyper. But again, polling the friends or phoning a friend out there. So if I was on one of them game shows, the majority here, 51% got it, right? It's hyper. So if we were doing a support group, and if I would just advance this whole slide here, the 80% of the patients that come in with autoimmune were hyper or Graves' disease. The other is equal. They're either euthyroid or hypo. So that's why we really don't see a lot of thyroid eye disease. And again, we might be missing it, and that's what tonight's about, because 10% of the people that would be in this group had hypo, and that's the majority of what we see in the United States is hyperthyroidism that's out there. So what causes the thyroid disease and the symptoms? This is where I said at that one polling question where everyone was kind of correct, is that you do get eye signs when the T3 and T4 are elevated. So let's say you're in a early onset of thyroid disease, dysfunction, autoimmune, and your body has made more thyroid stimulating immunoglobulin. It's hitting the receptors. You get the burst of T3, T4. You do get some eye signs, but that's not inflammatory, right? It's just because there's so much T3, T4, your body's reacting to it. It's this congestive disease that we optometrists can really shine and help out our patients in unraveling. You probably have a patient in your practice that is not viral, is not allergic conjunctivitis, it's not bacterial. They have this chronic inflammatory conjunctivitis. You've been dumping Lotamax and steroids on, and it feels better. Then you take it off, and it lacks and wanes. I bet you if you had that patient in your practice, if you would go and look, they're probably on Synthroid, and I bet you if you'd ask, they were probably autoimmune rather than some type of iodine or cancer-induced. So secondary and tertiaries, it would probably be primary, meaning autoimmune. So this T3, T4, remember, is not an inflammatory. It's the antibodies that are formed. So again, you have the thyroid eye disease in two phases. You get T3, T4. Then that normalizes in a sense with the Synthroid. And that's kind of where, Joe was talking about with his patient, but it also sounded like there was some chronic inflammatory issues going on. That's the second phase. This is where optometry can shine. And this is where you have to kind of know this lecture really well, because you have to call up and talk to PAs and endocrinologists and primary care docs and say, it's not that I'm a crazy optometrist out here. It's because it has nothing to do with the T3, T4, TSH. It's the antibodies, the immunoglobulins that are out there. So when we did that one polling question, and I said I have a slide that will kind of show you that, it was an okay worded question, but I did it on purpose that way. You do get side effects when you're in that early stage. You don't have the antibodies attacking the orbit, where you do get excess hormone drug acting on nerves, the spastic stare, the dryness, the lid retraction, and then you do get some fluid stagnation and periorbital edema. Once the synthroid and T3, T4, TSH normalizes, and that's where the doc goes, that's where the primary care doc goes, well, can't be thyroid eye disease because your T3, T4 is perfectly normal. That's not the disease that we're going to be focusing on right now. So if we're relying on chronic inflammatory disease with T3, T4, there will be a lot of failure. It's this congestive side right here. And there is actually now a new grading system that's out there that we were going to talk about. I've been saying for years that we used the no specs and we used the LEMO, and it really wasn't great because it didn't tell us, was it inflammatory? Was it congestive? Was it plateau? And now in order to bring the Tepezza to market, there was a new grading score that we'll talk about in a few slides here. But this is the congestive. It's either active because the antibodies are attacking the receptors, you're kind of in the plateau phase, or in the eye, you're in the resolution phase because, again, there's only a finite amount of receptors that can be attacked by these antibodies that are out there. So you're kind of trying to determine the active, plateau, resolution, and you can step in. So now let's just talk real quick. How does someone become a euthyroid? You've been hearing me hammering about these antibodies the whole time. So if you think about it, it's a receptor disease. If you get too many thyroid stimulating, and I'll just say these blue, these blue would be the antibodies that have been produced. Really shouldn't have them in your body, but your body's produced them for whatever that reason is. And it hits the receptors and creates that burst of T3, T4, then you got a larger amount of TSH. But what happens is if you have the right amount, equal amount, the blocking and the stimulating, so you're getting some stimulated, some blocked, the T3, T4 never really goes out of sync, but you have the antibodies that can go and attack the orbit because the orbital structures, in the eye, the muscle and the fat mainly, are the ones that become inflamed. And that's how you end up with a euthyroid condition. Now, my guy eventually ended up on Synthroid and eventually his T3, T4 going out because eventually the receptors were so damaged that even though the TSH was coming down, that's the guy I started off the lecture with, even though his receptors were damaged, the TSH didn't really have anything to work on because of the damaged receptors. So in all three of these people, my point here is, and you can kind of look as you go across, the first one here, you can still see some redness to the eyelids and some edema. This one still has edema, but the eye is not red. And this one's kind of maybe in between. And I should maybe reorder these where this is kind of the active phase. I would say this is resolution, pretty white and quiet, but then you have the lid retraction and maybe heading towards a resolution phase. This might have been redder at one point. This is still pretty active. My point is, how did these eyes end up like this is because these antibodies are attacking this orbit. It's an orbital disease, and it could be thyroid stimulating, it could be thyroid blocking, or it could be a mix. It could be thyroid peroxidase that's out there. And this goes back to a patient that came in. And this is, again, how this probably happens weekly, if not, every other week, someone comes into the practice, definitely monthly, where, hey, doc, I've been on these Lotamax and Maxitrol, doctor in a bottle, Toberdex, I've been on this, and it doesn't seem to be dry eye. I've been tested for dry eye. I have all the, not really this and that, but I keep getting these red eyes. So now it's awesome because a lot of people have access to, their records. You can pull it up on their phone, look at it. This patient was able to write down, okay, look, yeah, I was on Synthroid and my TSH and so on and so forth. But again, everyone was focusing on her TSH or T3, T4. Her eye symptoms began here. She was making some notes going back and doing the history. And I said, well, look, you could test for these antibodies. I said, let's test for your antibodies. And we did. And you could see here, it says thyroid immunoglobulin antibodies less than 1, peroxidase is 11, and her thyroid stimulating was 344. So as you go over here and you take a look, these are all normal values. And what I saw as a reference, 1.75 international units per milliliter. She wrote down on her lab, showed that less than 1.3 or 1.75, doesn't really matter what number you use. She was 344. She was through the roof with her thyroid stimulating immunoglobulins. Again, it's not a T3, T4 problem causing the eye. At this point, it's arthritis. I love calling it arthritis. If you think about the eye, it's a ball and socket, right? And if you look at a skull, it's a socket. You put an eyeball in it, it's a ball and socket. We talk about synovial membranes. Synovial membranes are in your joints. The eye has a synovial membrane. We just don't call it that. Dr. Teenan gets the credit for finding it. We call it Teenan's capsule. We should call it a synovial membrane. And then it reminds us that the eye is nothing more than a ball and socket. And that's why rheumatoid arthritis, being a collagen vascular disease, an autoimmune disease, lots of collagen and elastin, synovial membrane, Teenan's capsule, tons of connection that's out there with this autoimmune and the eye. That's why we see a lot of findings. But if you take a look, 344, that's what was causing her issue. Wasn't the T3, wasn't the T4, the TSH. It was these antibodies creating this arthritis, this now inflammatory disease in her orbit. So we've all been taught the general ocular symptoms, the stare, the pain, the lacrimation, the eyelid swelling, foreign body, blah, blah, blah. We're good at that. And then there's no specs. I like no specs just to remind me that there's no signs or symptoms. The upper lid's involved, soft tissue involved. But all this is saying as you go down the list is that you're entering into more chronic inflammation, ptosis, you got extraocular muscle involvement, corneal involvement loss, and sight loss you can get from a congestive ischemic type of optic neuropathy that can happen in the orbit. And that's why when someone answered way back in the polling question, neuroop is a good answer. But it's kind of the end stage. It's an orbital disease, which then can eventually lead to the crushing of the optic nerve and vision loss. So I don't really go into no specs. I have it in here in the notes just to kind of remind. I don't use it. The LEMO classification reminds us that there's lids, exophthalmos, muscles involved, optic nerve, again, in this inflammatory disease. And you can different grading scales that are out there. Really not used much because, again, is it inflammatory? Is it inflammatory and active? And if so, is it resolution or is it more moving towards the passive phase?
Greg, a question came in asking, is there any correlation between thyroid eye disease and metarosis?
The only correlation, so the answer is yes. I've heard lecturers say that in all of their hypothyroid patient with regarding lashes of the lids and lashes or eyebrows that, I heard someone say the other day, I was in I forget where I was. I've been in a lot of places since the beginning of the year, but someone said, oh, every patient I have that has hypo has an outer third of their eyebrow missing. It does have issues with lashes. It does have issues with eyebrows. I'm not strong to say that every single person is going to have some type of, say, eyelash or eyebrow follicle involvement. And that's kind of where we go to here with this now clinical activity score. The clinical activity score, you might hear them talk about the CAS, right? Or if you're going to order Tepezza, the doc that you're going to send them to, where are they on the CAS scale? The CAS, the clinical activity score. The thyroid disease is characterized by severity. It's characterized by activity, right? So how severe is it? Are we going to end up with an optic nerve crushing? Or are we, and if so, is it active? That really tells us where we are. So this is what was used to bring, and this is what a lot of insurance companies are using to see if they're going to pay for Tepezza, is that on the first 7, and in my experience in referring patients over, it will get paid for if there's 3 or more. Now, you can certainly send them if they have 1 finding. Now, it's a scale, it's a table here of 1 to 10. This is 10 findings. I had someone ask the other day does pain on attempted gaze, does that count as 2? And then redness of the conjunctiva is 4, and that becomes 6. No, that's not how that works. It works as that this is painful feeling behind the globe is a 1. And pain on attempted gaze is another 1. So now we're up to 2. Oh, they don't have redness of eyelids. Oh, but they got redness of the conjunctiva. Now a 3. So these are all 1, 1, 1, 1, 1. And as long as you have 3 or above, to me, you're getting a good chance of getting this patient, if they have a chronic disease and inflammation, that Tepezza will work. Now, 8 through 10 is now for follow-up, and you can see here greater than 2 millimeters, 1 to 3 months, 1 to 3 months, so on and so forth. So it's more or less in the follow-up side. So you really want to use in the CAS system in initiating the patient whether or not they're going to get covered, and it's mainly by payers, and it's now a better system than the LEMO and the no specs that's out there. All right. So lid involvement, we talked about this a little bit. I'll go through some slides here, fairly quickly. We have lid retraction, lid lag. We have lag ophthalmos. And we can see here now going back, and I know you guys are going to get sick and tired of me hearing this. Again, this is not T3, T4. This is not, that early phase. We're talking arthritis of the eye. We're talking orbital inflammation, antibodies attacking receptors. And that's what's happening here, is that you could see the lid retraction that is occurring in both of these patients. And this one may be a little bit more active, and this one may be a little bit more passive that's out there. And as a reminder, the eyelid hits at this 10 and 2 o'clock position in a patient that's out there. So lid retraction, it could be from excess stimulation of the Mueller's muscle, and that can be in that T3, T4, but the fibrotic inferior rectus, the infiltration of the levator, increased volume is inflammatory chronic inflammation. So this is kind of T3, T4, and then the rest of this is the inflammatory part of this disease. Von Graefe sign, the eyes, you look down, the lid stays up. That's again another sign of chronic inflammation, right? Things are scarring down from this disease. Lag ophthalmos, pretty straightforward. You've got the eyes. We talked about the orbit. The easiest way for the eye to escape is to go out through the opening, and now the eyelids cannot close, and we have lag ophthalmos. This is probably where by tomorrow, if you're seeing patients, or by tonight as you're done with this lecture and filling out the survey, so on and so forth, you're probably going to think of a few patients that you've been hitting them with Lotemax and some type of anti-inflammatory, maybe some Xiidra, maybe some Restasis, trying to figure out strong steroid, immunomodulatory. Where am I going with this? You know it's inflammatory, just didn't connect the dots that this was a thyroid eye disease, because it's the soft tissue involvement, the conjunctiva, the chemosis, the periorbital edema. Like this patient here, you might think is a viral infection, but in a sense, it was thyroid eye disease at its best or its worst, and its active inflammatory phase here. Now, this is kind of neat. I have patients that come in and we'll have SLK, superior limbic keratoconjunctivitis, and pull the eyelid up, and you go over and say, oh, SLK. Let me click back here. Oh, I see you're on Synthroid here. Tell me about how that happened. Oh yeah, doc, 10 years ago. man, night sweats, this and that, so on and so forth, blah, blah, blah. You know, it took a while to get my T3, T4, TSH all settled down. Okay. Now you're starting to have soft tissue involvement. This is the inflammatory side of this disease. Years later, after T3, T4, TSH have all been normalized, that's out there, and you can see the inflammatory side of this. 65% of the time, it's SLK. It's a thyroid eye disease. Now, kind of ironic, if it's not, it's probably related to rheumatoid arthritis and Sjogren's, which are now two what? Autoimmune diseases, right? So again, when you see SLK, you know, it's probably some type of autoimmune condition that's out there. Back in 2013, sitting in the front row here, Joe and I were doing for OMS a meeting. We did their, for about 10 years, did their clinical program. And Dr. Morgenstern at that point said, hey, if the eye is red, think TED. Now, I'm not sure if he created it or whatever, but that was the first time it really kind of resonated with me, and thought about it with this lecture. So I'm just going to kind of say, you know, since 2013, we've been thinking about if it's red, think thyroid eye disease or think TED. Periorbital edema, inflammation of the subcutaneous tissue, maybe the first sign of thyroid eye disease. This kind of is, you know, easily missed at times. It could be subtle. We might blame it on patients as they get older and so on and so forth, and maybe some prolapsed orbital fat, maybe see if it is fat or edema. And you could see that the periorbital edema can be from thyroid eye disease. Infiltrative orbitopathy, it can be unilateral or bilateral, and exophthalmos should be reserved whenever it's thyroid eye disease. So proptosis could be from a tumor that's in the eye, and kind of like if I would say clinically significant macular edema, then I would know it's edema from diabetes, not a vein occlusion or some other side effect that's out there. So exophthalmos is typically, we want to say, even though it's used a lot, but it's really reserved for when the eyes are bulging from thyroid eye disease, and you might need an MRI that's out there. But look what's happening. Extraocular muscles, lymphocytic infiltration, proliferative of fibroblasts, edema, interstitial tissue of the muscle, inflammation, orbit, so on and so forth. Unilateral cases, sure. Bilateral cases, sure. Unilateral case in this patient here, probably in a passive phase. Down here, a little bit of redness, periorbital edema. Now we got an active phase. We should maybe do the CAS, the clinical assessment score on this patient, and maybe they would be a good time to reach out for. Now we have Tepezza, which we'll talk about. Joe's taught me that, you know, this is the leading cause of orbital of compressive optic neuropathy. Joe, do you want to kind of talk about the leading cause out there? And it's not really a tumors, but you want to kind of...
Yeah, everybody thinks compressive neuropathy is a tumor, but the number one is Graves' disease. These muscle bellies are enlarging. There's only so much room in there, and it can compress the optic nerve, especially the posterior optic nerve. And you know, there are a number of things that they can do to help give some room in there. Now we've got a very good treatment. You know, I've got a patient with thyroid ophthalmopathy, and an image, you know, MRI just came back, and now she's got good vision. She has no pupil defects. Color is good, acuity is good, everything is good, but her MRI is bad. And her MRI actually showed compression of the posterior aspect of the optic nerve from the superior rectus. So this is a patient, you know, while she is asymptomatic, is going to lose her vision if we don't do something. So this is a person that I'm glad I had the imaging, and it was really well done, and they found, you know, a posterior optic nerve compression.
And here's a really good image here of this muscle belly right here, and you can see this lateral rectus versus the medial rectus here, and you can just see how enlarged and infiltrative it is. And then I use this from Elsevier of 2005, this picture. giving credit. And you can see here's the eye, and then here's where the optic nerve. But look at these muscles and how they have hypertrophied. And imagine that, I think behind the optic, it's 1.5 millimeters, inside when you see it. But once it becomes myelinated, it's probably about 2 or 3 millimeters of an optic nerve that we're trying to survive and run through here and not get crushed and become that compressive optic neuropathy. We have, when it comes to exophthalmometry, that is race dependent, Asians versus Black men, and is statistically significant. So when it comes down to doing Hertel and Ludi in the office, do I do it on every single patient? The answer is no. Do I do it on every single patient that's on thyroid, or Synthroid medication? The answer is no. So who are the high-risk people? The autoimmune. So if they come in and they say, hey, I had some cancer, they were able to find it, they radiated it, surgically removed it, ended up on Synthroid. Okay, not to say that they couldn't have the antibodies, I get that, but the patients that I really want to do and have my technicians do a Hertel or Ludi on are the patients that are that definitely have some redness or swelling, and then also that are autoimmune that are out there. And you can see here that there are some normal values, but the difference is you start getting 2 millimeters between the two eyes, or anything that gets over 24, start scratching your head and maybe getting to that orbital disease, or thinking about Tepezza that's out there. We have restrictive myopathy. Kind of makes sense now that we know that the receptors, it's an inflammatory, the muscles can become involved, and now you can start getting some double vision with the patients. We'll talk about IOP disease in a little bit here coming up, from the orbital edema and so on and so forth. Restrictive myopathy, here you can see the eye turn that has occurred, but also take a look. This would be someone that comes in, it's like, oh, what's going on? This is a pretty classic case of thyroid eye disease. They have a restrictive myopathy, periorbital edema, conjunctival hyperemia. Yeah, I would definitely now be doing the CAS score on this patient, probably well above a 3, and off to maybe to a site that can do an infusion. We all know how to treat corneal exposure, so I'm not going to really dive deep into this. We're optometrists. We know how to deal with abrasions and so on and so forth. Here's that 5% of patients that we really need to be concerned about that can move into crushing that optic nerve, ischemic, compressive optic neuropathy in those pictures that I was showing a little bit earlier, and damaging that optic nerve. So now when it comes to treatment that's out there, there's this huge shift to Tepezza has really changed things that are out there. Really, patients, you got to know that CAS scoring system. And if they score, in my opinion, 3 or above, and your opinion could be a 1, and you could call up your infusion center or someone that's doing it in Pennsylvania. I cannot prescribe it. I have an Oklahoma license. I could prescribe it in Oklahoma, and then someone would still have to infuse it. But you have to find a place or someone, and just kind of use the CAS score when you're making that referral that's out there. But it has to be the active inflammatory. And I'll show you some pictures of some passive cases that are out there. So it's managing and controlling the inflammation. So it's kind of shifted that in my office, that if they're a 3 and above, boom, they're going for the Tepezza referral. But if they're a 1 or a 2, I still manage them the same way, kind of like what we were doing with the Lotemax and those patients that we were talking about, controlling the pain and the inflammation of the orbit. You could do that through lubricants and anti-inflammatories, Lotemax, Restasis, Xiidra. Some people can get some double vision. You can use Fresnel prisms in the office because those are temporary, as the patient may be getting some swelling, and the swelling then goes down. You have oral steroids and periocular injections, orbital radiopathy in the active phase, but then you can move into passive. When the eye is passive, you can then move into orbital decompression. Probably Tepezza now, with again doing education like this and catching these early and not letting them get to the point where they need a knee replacement, where they need a hip replacement, catching it early, intervening early, we'll probably see these orbital radiopathies and these orbital decompressions start to decrease. anyone that's autoimmune, anyone that's smoking, right? And I know there's probably people out here with thyroid condition. So 1 in 13 are patients have it, and there's more than 13 people on here. So I'm sensitive to that. But also I understand there's probably people that smoke on here, and it's easier to say quit than and stop because of the addictive side of that. I get it. But this is a condition when people come in and they have autoimmune. I really, really try to support the primary cares, the rest of the healthcare system to try and get them to quit, because it's going to be better for their eyes and their body.
Greg, if you go back a little bit, talking about the decompression surgeries, it does work. It can be done. Bone can be removed, but there, I think it's important to understand there's only so much that can be done there. Now, lateral wall, that doesn't really give you much room. It's really only the medial wall they can do a heck of a lot for, because that will allow some room for the muscles to expand. Inferior wall, inferior floor, now you can have a drop down in enophthalmos, and superior, now you're doing neurosurgery. You break through the superior orbital wall. Now they're looking at brain tissue. So there's really kind of only so much you can actually do with that.
Great, that's perfect. And there's actually a slide coming up a little bit, probably about 5 or 6 slides deeper, that can show you how much room. I'm not going to let the cat out of the box yet, but how much room that you can really free up by doing a decompression. So treating the lid retraction, there's the active phase, the passive phase. It's the surgical management, the muellerectomies, which is kind of what I'm showing here. This patient came in totally all burnt out in the passive phase, and she said, "Yeah, doc, I have thyroid eye disease. I get it. This is why I look like this." And I'm just like, "Okay, well, let's get you to an oculoplastic surgeon, and let's get you looking, get that lid back to where it belongs." And really, I've been seeing all these other eye docs out there, and I'm like, yeah, why don't we just get you and get your lid fixed? You're in a quiet phase here. You're in a passive phase. Let's just go and, get someone in it, that's an oculoplastic, and bust up that scar tissue, reposition. And she turned out awesome and was very happy. You can see here the redness and the swelling that's occurring. It's basically all the stuff that we're doing in the office. These are the patients that you might now recognize that you really wasn't sure. Go back and check. And we can do all the Restasis, the Zyges, the autoimmune, the immunomodulating type of medications, steroids, ointments at night. You can do diuretics and oral steroids. Usually by this time, I'm using the rheumatologist to manage the patient, because they really know how to manage autoimmune, like rheumatoid arthritis and so on and so forth. Here's that orbital disease consult that we were talking about, when that optic nerve is in jeopardy here. And then there's some non-surgical, teach the head the position with the myopathies, prism when they're active phase. I've always read about Botox, never really seen it done. Surgical consult, when they're in the passive phases that are out there, and an adult strabismus doctor that can help out with some of the double vision problems when they're in the passive phase. You really don't want to be operating in the active or inflammatory phase. We know how to fix corneal exposure. We talked about the optic neuropathies here. There's steroids. There's IV methylprednisolone. We talked about the orbital decompression, and this is what Joe was referencing here, is that this was given to me by the orbital disease doc, that I would encourage you to know where that person is. In my area, Pittsburgh, sometimes Geisinger has one, and then definitely in the Philadelphia area. So sometimes these guys are scattered. You have to know where they are. But you can do a 2-wall decompression and get 3 to 6. Just read through here, and you can see a 4-wall decompression can get up to 16 millimeters of mercury, 16 millimeters that are out there. It's not glaucoma, but 16 millimeters. You can see here starting superior, but like Joe said, be careful, because you'll be up in that frontal lobe area if you go too much. But it's kind of number 2 is nasal, and then going over here laterally. And then obviously the inferior floor is always the one that's most susceptible for blowout. So that's the order that they kind of go. Orbital decompression right here. You can see help this lady out on antidepressive meds, now off antidepressive meds, and very happy. And which reminds me that I found this is that when someone comes in, this guy comes in, you can see he's active. He's got lid retraction. He's got some little bit of periorbital edema, inflammatory. He goes, why do I look like this? Well, you're not going to say it like this. Your facial disfigurement is from thyroid eye disease. But when you tell people that this happens, it's equivalent to telling them that they have cancer or AIDS. So psychologically speaking, just be aware of that when you're talking to your patients. Be aware of patients like this. Why do they have this upper lid retraction? Why do they always look like they're staring? They don't like their facial disfigurement. I'm different now than others. Well, let's get that fixed and send this to like an oculoplastics person, and let's help them out with the depression that could be occurring. So you can see here, this was before, this is after of doing some decompression to those bones and fat that we were talking about. So when it comes to IOP, people that come in and that are thyroid, I don't consider them at risk for primary open angle glaucoma. They could be secondary. Like this guy here, I don't think his periorbital edema is going to influence his IOPs, but these IOPs might be influenced, or these IOPs might be slightly influenced. I would say this IOP over here in this left eye is probably going to be a little bit different than this IOP in the right eye. These might not be what they used to be back in the day. So it's more of a secondary type of condition that's out there that can cause, it's more of a secondary glaucoma rather than a primary. So any tobacco use can cause thyroid eye disease. I had a patient that had dipped smokeless tobacco. So yes, so I guess that's a good way of saying it. I should change my wording. Anything that's vaping is probably going to be with that, with all the toxins in vaping. And then, dipping or tobacco use, anything that's kind of going to be an external substance. I learned a new word, if I can say it correctly, exposome, right? That's kind of what the functional docs do. Anything that's kind of a irritant. When we talk like epigenetics, your genetics, but what can turn on genes to do certain things that are out there, that would be your exposome. So you are correct. So thank you for saying that, Jeffrey. So laboratory tests that are here, that are out that we could talk about. Again, this is just for your completeness. We're not going to really go through it, but it's for your thyroid hormone levels. This is kind of like the T3, T4. This is really what I want you to really remember tonight. And then to remind everyone that you can order this, right? Your hospitals are not, at least my hospital does not have the ability to be able to do thyroid antibody testing. They have different panels of thyroid panel number 1 is T3, T4, TSH, and thyroid releasing, TRH. But then maybe thyroid 2 is everything that I just told you. They're taking and looking at the RT3 uptake. Maybe they're looking at some other things, but my hospitals don't, but they could still draw the blood and send the patient to like Quest Laboratories and get the results. So I solve a lot of mysteries by ordering thyroid antibody panels and then using what I showed you before, those references, or they come with references on there, seeing if there's anything that's high that's out there, and then causing the thyroid eye disease. So laboratory testing that's out there. We have hypo. You can see what happens in the different treatments. Again, this is just in here for completeness. Now, I've said it quite a few times, but we're going to do the poll to kind of make it interactive. Which biologic drug is indicated for the treatment of this patient? This patient down below. This is a great patient. Came into my office, and actually my technician made the diagnosis. He, again, 7-to-1 ratio, he, older, was missed in multiple, trying to figure out what was causing his dry eye. And it really wasn't dry eye. I actually had an epiphany over the weekend with this patient, thinking about this talk, that I'm actually going to call him, because he came in, when I used to say, a year too early. Because Tepezza, which is the answer here, as I see them rolling in, and most people are getting the answer, is that, and I'll share the results, is that oxyrvate, that's neurotrophic keratitis. Tepezza is the one that causes or to treat the thyroid eye disease. Actemra is an assistant to giant cell arteritis, and Avastin is used for many things, but in the eye, it's used for choroidal neovascular membrane. But Tepezza here is the biologic for treatment. It came out in 2016. I'm sorry, came out in February of 2020. So February of 2020. What happened then? That was COVID, right? So COVID hit, and that's right when this was FDA approved. So it's there, Horizon's done a great job of getting the word out now that the world is, in a sense, opening up. He was told nothing else could be done. You could see the periorbital edema. You can see the marked inflammation, the chemosis that's occurring to this gentleman. My technician came out and said, I think it's thyroid eye disease, but hey, you're the doc. But that was my opinion. That was her opinion. But take a look. Oh, I don't have well, maybe I do. Let me see if I have them here. Let's see. Yeah, I do. Coming up here. What I want to show you is I have them out of order. Look what he has right here. He's got myopathy. He's got double vision. He even complained of double vision. So you can tell where he is in this disease. So going back now and looking at this, he has thyroid eye disease. We can use the CAS score. Did he have a painful feeling behind the eye? Yes. Does he have pain on attempted gaze? Yes. Does he have redness of his eyelids? Yes. Does he have redness of his conjunctiva? Yes. Does he have chemosis? Yes. So he's like 7 for 7, right? Inflammatory eyelid swelling. Boom. Inflammation of the carbuncle. Absolutely. Or the plica. 7 for 7. Boom. This is a great case right here. Great person for Tepezza to get off. And my epiphany is I have the dates here. I lost them to follow up because I sent them to rheumatology. They was doing IV therapy on him. It dawned on me that if he hasn't had a chance to have Tepezza, it doesn't have to be, it's not like early, just as long as it's not burnt out, it has to be an active phase. So if he's got a 3 or more on his symptoms, I'm going to call him and discuss with him to see if he's had Tepezza treatment. So here he is here. You can see we started him on some eye drops, started him on some orals. You can see he started to improve over time. The redness started to improve. What I didn't like and how I lost him to and how I had to lose him to follow up was I had to get him to Pittsburgh. I didn't like that he was having double vision. And I needed an MRI. I wasn't sure if he would need fat decompression, radiopathy, bone decompression, so on and so forth. That's out there, but he did improve. He was happier. You can see here, less redness, less swelling than when we saw him on March or February 25th. But you can see here quickly, I lecture with Dr. Tracy Offerdahl. You guys have probably seen us, heard the two of us speak, maybe live or at a webinar. She quickly pointed out, look how quick within a month time, how fast this fat distribution occurred on this patient. So you could see the side effects of the oral steroids just within a month's time there. But you can see here he was improving until we lost him because I didn't like the double vision. You can see I've had him for about 2 months here. You can see that eye is still turning in a lot quieter. You can see again the moon face from the steroids. Steroids are great, but they also have some side effects. The immune system does not like to be tinkered with. And you can see a lot of the swelling has gone down. The right eye looks great, but just like any chronic inflammation or diseases of the eye, usually worse in one eye than the other. And that left orbit was definitely worse than the right orbit. So this was pretty cool. I was flipping through a magazine back in 2018. You can see here December 18 issue. Chicago teprotumumab was saying that it's an investigational study of the IGF-1 receptor antagonist, and if approved by the FDA, Horizon Pharmacy would be the first drug for the indication of thyroid eye disease. Very cool. So I watched it over time, and again, it did work. So how does Tepezza work? Polling question number 7 is teprotumumab, which the MAB at the end tells us that it's a monoclonal antibody, tells us that it's a biologic. Its trade name is Tepezza. Does it work by blocking the TSH receptor? Does it work by blocking the thyroid blocking antibody receptor? Is it working by blocking the thyroid peroxidase? Is it blocking all of the receptors in the orbit? Or is it the IGF-1? What's it blocking? How is Tepezza working? And we're getting them to roll in.
Tough question.
It is, but important in the mechanism of action of this medication. Because I've been hammering the whole time about this thyroid stimulating and thyroid blocking. So let's share the results. And again, that's what I was hammering TSH blocking and the antibody receptors. It goes back if in the article that I just showed you here, it's the thyroid, it's right here. It blocks the IGF-1 receptor. And I'll explain that here in a second. It's really cool how this works. So teprotumumab, again, this U in here, this mu tells us that it's a humanized type of monoclonal antibody. It's Tepezza. It's by Verizon Therapeutics. It's a biological. It's made by the Chinese hamster ovary. So they figured out this molecule, this blocker. They use a Chinese hamster ovary, and then they spin it. And once it comes out of this chain, they form it into the protein that blocks this IGF-1 receptor. It's a monoclonal antibody, the insulin-like growth factor number 1. It's an infusion. Anytime you see biologics, they're huge compared to aspirin. I mean, they are giant molecules. That's why you can't really swallow them. They're usually injected into the body or infused into the body. So because they're so large and again, so delicate, and you can't really shake them. It's like a ball of yarn that's been twisted up and laid out. And if someone just walks by and just trips over it, it can just mess up that ball of yarn or how it's laying out on your floor. That's how these molecules are. They have to be handled very, very delicately. And that's just probably a rule of fact for all biologics that are out there. So they did go and they had it phase 2, phase 3 studies. It was March of 2020 that it was approved. Again, right when the world was shutting down, that's when Tepezza was approved. So I like these slides right here to remind us that it is an orbital disease. You can see they did a great job of showing the inflammation in the orbit. And the key is, if you just imagine this being a muscle cell or a fat cell that's in the eye, and this is from Tepezza.com, I just snagged these pictures off of that, you can see that there is a thyroid stimulating releasing hormone receptor. There's also an insulin growth factor 1 receptor. And as long as you have one of these stimulates, the guys that said the thyroid releasing are correct, if either one of these are stimulated, either the thyroid stimulating hormone receptor or the insulin growth factor receptor, this little bugger down here is the kicker, this beta arrestin. Because it actually joins these two receptors, if one is stimulated, it's like having both stimulated. So this little beta arrestin creates a little bit of issue. I forget what they call it. It's a co-something receptor. It kind of binds them. So, but where does Tepezza work? It doesn't come in and bind as we would think to the thyroid stimulating receptor. It actually binds to the insulin growth factor 1 side and causes it to downregulate. And I like this picture here because this is what can happen whenever we talk about oxidative stress that happens in the body. And that's why good nutrition can help and so on and so forth. And we're helping with the downregulation, upregulation, or allowing the receptor to work properly. But what it does here is this Tepezza comes in and it attaches to the insulin growth factor 1 receptor and basically shuts it down. In other words, downregulates it, turns it off, for lack of a better term. So even if the thyroid stimulating hormone comes in and beta arrestin is there, it still does not allow it to turn on and create the chronic inflammation. So really, really cool. Immunosuppression that's out there. I have a whole 2-hour talk on biologics, but immunosuppression biologics, biologics have been around for years. Oop, I got a typo right there. But the first ones were Remicade, right? A lot of sensitivities with Remicade that was out there. It was a chimeric type of molecule. It means a mouse and human were involved. And then we have Humira that's out there, and it's a fully humanized, and that's why you see less sensitivity. That's why when you hear about biologics, chimeric versus a fully human protein. And then you move down into these biologics are here to stay. You're seeing them on TV. I just looked up, and then TV's on in the room. There's a commercial on talking about a biologic. And this one now is more of an immunomodulatory, rather immunosuppressant, because it's so specific, so targeted that it's not messing with the whole immune system. Like when people take Humira, you got to test them for TB because it's so immunosuppressive. This is more of immunomodulatory. So don't start lumping everything in together when it comes to this. So Tepezza is that insulin growth factor 1 inhibitor. It's fully humanized monoclonal antibody. What does that mean? More focused effect. It has less sensitivity. So again, Remicade back in the day, lots of side effects that's out there. And look what it's doing. It's working on the orbital fibroblasts, 2 myoblast or 2 adipocytes. That's what creates along with the hyaluronic acid and the glycosaminoglycan, all things that create fat muscle swelling, the fat adipocytes, the myofibroblasts, hypertrophy, hyaluronic acid, glycosaminoglycan, creating the swelling that's occurring, throwing off and creating that inflammation that we talked about a ton tonight. There were studies that brought this to market. It was the Optics and the Optics S. They looked again, this is why it's important to know that clinical activity score, that spontaneous pain and all that we showed earlier, I might have it coming up again, scale of 7, needed 4 to be in the study. So again, once I have a 3, that's whenever I reach out to the infusion site. But you could reach out at 1. If a patient has a 1, you could certainly reach out. But this is what I'm finding. I'm the third-party chair for Pennsylvania and work with a lot of the payers that are out there. They're pretty much using the CAS system in about a 3 or 4 or more, and then they'll start covering the medication. And then you saw improvement of ptosis, the double vision, and then just the quality of life score was how they brought this to market that's out there. And obviously it came to market, so they saw improvement in proptosis, diplopia, and the quality of life score that was out there. And again, there was more than one study. One was the Optics X. 83% had 2 millimeters or better improvement over the placebo, 10%. The average was 3.2 millimeters at 24 weeks. Diplopia, 68% improvement, 1 point, and then 29 as compared to 29% with the placebo. And then the quality of life score, placebo was 1.8, and it improved. If they were at 100, they would have gone down to about an 83 or an 84 because there was a 17% improvement. So patients that are out there that are having thyroid eye disease, keep that CAS scoring system nearby, and then that would be a good way whenever we would be sending the patients to an infusion site, or at least talking to the endocrinologist or the primary care doc about I have to do that in Pennsylvania to get it ordered. So the most common adverse events that were greater than 5% than the placebo: muscle spasm, nausea, the alopecia, diarrhea, hyperglycemia. That's kind of neat, right? But it's no surprise if you think about that it's working on the insulin growth factor 1 type of receptor that's out there. You can get infusion reactions with any of the biologics that need to be infused. You have to be careful of infusion reactions. Again, hyperglycemia, increased blood sugar occurred in about 10% of the patients that were out there. Again, it's working on the insulin growth factor 1 receptor. So patients with pre-existing diabetes should be, in a sense, euglycemic or controlled before beginning treatment. You want someone that is not controlled, because you're going to further throw that out. It's out there. The question that just rolled in is how many infusions. It's right here. It's 8 infusions. Sorry, I didn't cover it or make it clear. 8 infusions every 3 weeks for 24 weeks. So Jeffrey, thanks for pointing that out. So 8 infusions every 3 weeks in the course of 24 weeks. That's out there. All right. So go forward. So an infusion center, you know, I know my endocrinologist in town is doing it. So that's always a great source. I work well with him, work closely with him regarding diabetes patients and thyroid patients. So he's just a phone call away. He'll ask me the CAS score. Great, Greg, that's awesome. Send the patient down, make an appointment, and we'll see what we can do for them. If you're not sure, go to the Horizon website, do the contact us, find your local rep. You know, they're out there. I've been seeing them at the meetings. You know, type your question is looking for an infusion center, looking for someone nearby that's out there. Off-label uses of biologics. Let me just point this out because I get this question a lot. These 4 letters at the end, these really don't mean a darn thing. Looks like someone leaned on the keyboard. What that is that because there's no generic, what you hear, they're called biosimilars. It's the same exact, another company can get the DNA sequence and put it in and create that molecule. Now they might have a different way of doing it. They might not use a Chinese hamster ovary, but they're still going to end up with a molecule that is going to be an insulin growth factor receptor 1. So there's no generics. They call them biosimilars, but yet the processes are different that are out there. So it's just a way when they plug them into a registry to see if one's working better than the other. So TRBW means absolutely nothing. If another biosimilar comes out, it's going to be called teprotumumab because that's what it is. But it will be a different 4 letters to see that over time to see if one is functioning better. I put this in here to remind people that there are other biologics that are out there, big boy biologics, CD20, tumor necrosis factor. They're using this, and I had a patient the other day that they were using like one of these biologics, and I can't remember which one, but I said, look, you might want to go. These are big boys, create a lot of side effects. You might want to go. And I talked to the endocrinologist, and he said, yeah, send them over. We'll consider doing that, making it more targeted. So that kind of wraps up in the next few minutes here. We'll land this right on time here, maybe a couple polling questions, but it goes back to now, can we help these patients understand what's happening, at least, you know, as maybe from a functional side. And this is, like I said, this has been really rewarding. I started 3 or 4 years ago. And it's neat to go and be able to apply it because we're talking thyroid eye disease. We see macular degeneration. We see with patients with diabetes that's out there where we can intervene in an oxidative stress, or in this case, it's going to be more of the thyroid, but it's all connected, right? The immune balance, the gut, the hormones that we talked about in that symphony that we talked about. So I mentioned this earlier, so we don't have to run this poll, Joe. It's which hormone is produced by the thyroid gland at 95%. And I mentioned it really, really early in the talk is T4 is what's produced 95%. Drawback is it's not active. T3 is the active form. So it's kind of a prodrug, and then it needs to be converted. That's out there. So this doc right here, Philomena Trinidad, she was awesome. I loved listening to her. She was talking about what affects the thyroid function. So you have the production of the thyroid, right? See, here's the pituitary, the TSH, and then you have the thyroid gland. At the gland level, which nutraceuticals out there are important? It's in the list here. We usually think this when we hear thyroid, selenium and zinc, super, super important. But let's take a step back. When that thyroid stimulating hormone hits the gland, the receptors, that gland needs to be properly, has the proper nutrition, iron and iodine, tyrosine, zinc, and selenium. There you go, zinc and selenium. But beyond that, with the iron and the iodine and vitamin E, B2, B3, B6, C, and 9 that's out there. So that's just to get that 95% of the T4, but now we have to convert it. and we want to convert it. And that conversion, that's where you hear people say, well, yeah, zinc and selenium are super, super important. They are, but look at how much is important to be at the gland itself. Zinc and selenium, I've heard Tracy, who I lecture with, they're wanting to do a ton with the Synthroid and the patients are having problems. And Tracy says, let's get you on some zinc and some selenium. And then all of a sudden the T4 is able to be converted over to T3 to be used. The patient was more or less selenium and zinc deficient, not that they didn't have enough T4, it just wasn't converting. Now you have to get the body runs off of T3 and it has to get to the cell nucleus. And this is where, again, having cells that are not oxidized that are out there, using vitamin A, B2, B6, B12, exercise, zinc, iodine, and selenium that's out there. So patients now are coming in and, in a sense, expecting a little bit of discussion with this. And that's why I wanted to kind of fold this in. We've grown up on this allopathic side, but now we're getting into more integrative or complementary. And you have to understand this because the patients are asking about it. They can go to Google, they can go to YouTube and read about it. So that's why I wanted to talk about it tonight. So going back to thyroid function inhibitors, going back where we talked about pituitary and the thyroid stimulating. And again, these are her slides as she was lecturing. So I'm just making sure she gets credit for this. This doctor here. And so you could see here at the gland, in a sense, stress, infection, fluoride, toxins, autoimmune disease, or celiac, selenium deficiency, starvation. All these crazy diets starvation diets can really affect that thyroid gland that's out there. So, but look, it's also talking about chronic disease and decrease kidney and liver function that's out there, right? We always kind of think of things in silos, but now this kind of more holistic approach when it comes to thyroid. So thyroid function factors decrease in that conversion from T4. Remember, 95% of it's T4. It needs to be converted to T3. Now there's stress, right? Maybe that cortisol that we talked about, or trauma, or a low caloric diet that someone's doing. So again, we're always trying to influence it with Synthroid and different, kind of medicines, but it could be that they have, liver or kidney dysfunction or other medications that are out there, just not allowing that T3 or T4 to convert. It could be beyond, again, those antibodies that we talked about so much. And here she's just going through talking about phase 1, phase 2, and oxidative stress. Oxidative stress is huge in the eye, and we can help a lot of people out there. So with that being said, these are the signs of thyroid eye disease. As I was putting this talk together, I had no idea that there were so many signs to thyroid eye disease. Boston sign, jerky, irregular movement of the upper lid on downward gaze. The Griffith sign, lower lid lag on downward gaze. Like, there's all these different signs that are out there, pretty crazy, but it's just there for more fun. So the last slide, or the last polling question I'd like to launch here is, after listening to this presentation, I think I might have a patient in my office that has thyroid eye disease that you might not have recognized, or now hopefully this lecture has helped you to say, hey, there's probably someone there, and now I have a better grasp of what's going on.
I think you've probably changed some behaviors with this talk, Greg. I think you've enlightened a lot of people to the myriad of what constitutes thyroid eye disease and thyroid dysfunction. So I think it was tremendous. And I'm going to end the poll right now because
I know why you're doing it.
Ladies and gentlemen, we have a first. 100% for one answer. We have never had that, even when there was one answer.
There we go. There it is, our 100%. So good. I'm glad that's why I love teaching. That's why I'm glad a lot of you are here tonight. I'll say thanks to everyone. If I don't see any other questions that have rolled in here, thanks for everyone taking this. I don't see any questions. This was thyroid dysfunction and thyroid eye disease. Everything you need to know and a little bit more. This was an interactive distance learning course. Thank you, everyone.
And thank you, Greg. I thought it was fantastic. And of course, you're beginning to get your virtual round of applause as expected.
Perfect.